We have covered most of the sessions in symptom management, communication, and ethics. So today we are going to talk about end of life care. You may think that it's important to talk about end of life care because you might have seen many people dying and you have managed those patients. But I would like you to think about what we have done in the past. Are, are those things the right things to do? Can we do something else? We have been following a pattern while the patients are dying. We will inform the caregiver. We will be doing CPR. We will be giving injection hydrocortisone, oxygen, etc. So this is what we have learned during our medical school, and we have also seen that our seniors are practicing like this. Our teachers are doing this. So, is there anything else that can be done for those patients who are near end of life, or what are their preferences? So let's go through this class by Rajagopal sir. So uh, he is the director of Trivandrum Institute of Palliative Sciences and chairman of Pallium India. So sir, it's over to you.
Thank you, Sunil. Thank you, Raju. Hello, everybody. Good afternoon. I hope I am audible.
Yes, sir.
Your foundation course is almost coming to a close, right? So some of the things that I talk about today may turn out to be repetition. Particularly to some, I see Chetana here. Chetana has heard me talk about the same thing roughly 73 times so far. So apologies for the repetition. I may be coming back to some of the things that I have mentioned during the introduction to palliative care also. I am starting with a question to you. Hey, Raju, please make me co-host so that I can share my own screen.
You are, sir.
Okay, thanks. So, everybody, you are all doctors. Suppose I am coming to you with any illness. It can be a common cold. It can be it may be a gastric upset. It may be a terminal illness, whatever it is. As a doctor, what is your duty to me as a patient? Oh, this is not about Rajagopal. Any patient, what's your duty of care? What are you supposed to do for the patient? A silly question after your MBBS and post-graduation and all. This is defined by law in some countries like UK. In our country, there is no law on the matter, but there are ethical guidelines. So would somebody like to tell me what you think is your duty of care to me? You, Dr. Bijli thinks it is to reduce suffering. Dr. Sandeep Kumar says to listen to me and to ask for my expectations. Very good. These are both excellent answers. Does anybody have anything else to offer? To take care of symptoms, to make me comfortable, listen to me before proceeding. Very good. But now let me ask you a more direct question. Do you have a duty to keep me alive for a longer period of time?
Sir, another answer is to provide comfort and hope.
Yes. I am looking at the chat, so thank you, Sunil. Only when I start screen sharing and I put it on slideshow, I'll be able to, then I'll not be able to. I see excellent answers here. Very good. I'm happy with all of them. I am now asking a direct question. Do you have a duty to prolong my life? In addition to whatever you have said, I am coming to you with a health issue. You certainly have a duty to treat that. Is it only to make me comfortable? So even if I am coming to you with a chest pain from cancer, you will just give me comfortable, make me comfortable with morphine and send me away? Reduce suffering, yes, excellent answers. But are we missing? Now, all of you are thinking so much like palliative care person that maybe we are forgetting the disease. We shouldn't overdo it. One common criticism against palliative care doctors is that we concentrate on symptom relief so much that eventually the patient tends to miss a chance for a curative treatment. Not common. Very uncommonly, it is possible. But so let us be conscious of this. As I said, in our country, I'm looking at the answers. Thank you, everybody. I'm not naming each one. Okay. Sandeep, thank you. Sandeep is agreeable to prolonging my life, provided I'm not vegetative. Even if I am not vegetative, Sandeep, if it is full of suffering and you cannot take away the suffering, as for example, I am not vegetative. My respiration has failed and you have put me on a ventilator. By no means am I vegetative. I am conscious. I am communicating you even with a pad and pen on a ventilator. Okay, these are some other questions that we will be answering now. Can you see my screen now?
Yes, sir.
As many of you correctly said, you have a duty to relieve suffering, but also to cure when possible. Let us not forget that. Cure sometimes, relieve my comfort often, and to comfort always. This is something from a 14th century statement. The ICMR has continued this, and I would encourage all of you. Raju, you will be sharing my presentation with them. That link is given at the bottom. I would encourage you to open that. It's available for free download. It's a long document, but I would recommend that you please read the executive summary. That executive summary, among other things, talks about this sentence. The doctor's duty is to mitigate suffering. It is to cure sometimes, relieve often, and to comfort always. There exists no exceptions to this rule. Relieving suffering doesn't mean that it takes you away from your duty to cure my disease also. So that we'll take for granted and continue. Perhaps we talked about this in the beginning. One error of omission that we do in the end of life or all through the illness is that we do not treat pain and suffering. Only a small percentage, less than 4 doesn't mean much. Maybe less than 2 is closer to this. We don't know exactly. We are using various calculations to work it out. But certainly not more than 4% has access to palliative care in our country. And 55 million Indians are pushed below poverty line by catastrophic health expenditure every year. And the Economist Intelligence Unit, who in their 2015 report, studying 80 countries, has put India among the worst 15 countries to die in. And the reasons are the errors of omission and the errors of commission that I mentioned so far. And I may have quoted this to you already by Dr. Sankhamitra. In India, the poor die in misery and neglect. Excuse me. Sorry. रुकावट ले लिए खेद है. The poor die in misery of neglect. The middle class die in misery of ignorance. The rich die in misery on ventilators. No one gets a pain-free and dignified death. I don't know whether I have told you this. I am an anesthetist. I was an intensivist. I know what kind of life people live in the ICU. There are some aspects of it that are vitally important. If I have a curable illness, it's causing respiratory failure or even multi-organ failure, your intensive care for a few days may save me, because in intensive care unit, what are you doing something special that you are not doing in the wards? You are measuring organ function minute to minute. Those screens that you see behind the patient can measure your heart, not only heart rate, BP and ECG, but even your cardiac output and your peripheral perfusion indirectly. It is telling you everything. And if there is a dysfunction somewhere, if the heart cardiac output drops, you will know immediately, so that you can intervene now with an inotrope this minute and save me. That is the purpose of intensive care. Minute-to-minute monitoring and minute-to-minute interventions for all organ functions. This is the remarkable thing that we are doing in ICU. There is no ethical guideline that the family should be kept outside. That is something that we did partially to prevent infections and partially because it's convenient for us. More and more is being recognized for the patient's emotional needs. All of you will accept that the mind has an effect on the body. And a scared, panicky, anxious, stressed person in the ICU, naturally his stress will have a consequence on the circulation, on his peripheral perfusion, and therefore in the West, according to the estimates that I heard 2 years back, in the USA, 27% of all intensive care units are now getting the families in. They provide a couch for the family member. Of course, they screen the person for any infection, etc. They give basic training in hand hygiene and use of mask and gown. And they make sure that the family is with the patient if they want to be. Majority of people would not have a family member willing to stay in, but where they are encouraged. So these are some of the things that we do to our people. Look, even at my age, there may be a justification for you to do this. There would be a justification for you to do this if there's a reasonable chance that my life can be restored and I can get to a life with a reasonable quality of life. But if I am dying of an incurable disease like cancer, and you are stretching out my dying process by 3 more weeks by artificial life support. That is against all laws of nature. That's against my interest as a human being. Because every moment of that existence in the ICU, I know, is agony and suffering. A tube in every orifice, and particularly the one in the trachea, is intensely painful. And a suction catheter going in is absolute agony. If you are forced to lie in a certain position and you get a cramp and you are unable to move by yourself, what agony will that be? So maybe we need to rethink back to that doctor's duty, certainly to cure, but also to relieve and to comfort. And we have the duty to mitigate suffering. There is no exception to this rule. Parthasarathy Shom was the former Prime Minister's financial advisor. And after his mother's death, he wrote this article in the Business Standard. And when Raju sends you the link, I would encourage you to read that one pager. It's a op-ed kind of thing. So he says, he was told that his mother cannot recover. But still she was in an ICU. On the last day of life, he went in and saw a blood sample being drawn for hepatic function test. He asked why. Will it end the coma? No, it won't be. Then why are you doing this? He was informed that it was their responsibility to make available all procedures until the very end, irrespective of other practices elsewhere. Other practices elsewhere was interesting. Do you think this kind of thing happens in all countries? Is the standard of care globally? I saw some of the chats. Thank you. I am asking you, do you really think this is standard of practice globally? Interestingly, I have data. In the USA, maybe the highest technology users, apart from Japan, and in Western European countries, especially the UK, France, Germany, Netherlands, Scandinavian countries, they all withdraw the ventilator if treatment is supposed to be futile. In fact, we have data to show that both a US study as well as a Western European study both show that the majority of patients were taken away from the ventilator if treatment was considered futile. Interestingly, in India, only 22% of people are taken off the ventilator if treatment is futile. So in our poor country, where we cannot afford it, we are overdoing it so much more than Westerners. Important point I am making is our practice is not standard of international care. We are doing much worse, which is why India is among the worst 12 countries, 15 countries to die in. Not only because we don't provide palliative care, in addition, we are inflicting palliative care. So doctors, as your future patients, I am appealing to you. You do not have a responsibility to keep my heart beating a bit longer if I have an incurable disease. You and I have to recognize that every life has to end someday. Sorry, yours also. If a reasonable quality of life can be maintained, all of us or almost all of us would like that to happen. It would be nice to stay alive for a while more. But if that existence is worse than death, then what's the point in stretching out the dying process for 3 more weeks? Most emphatically, I repeat again, you ethically do not have a responsibility to keep the heart going a bit longer. And I say this because especially the doctors qualifying in the last 20 years very often come out of the medical college with a feeling that they have that responsibility. That's not their fault. That is our fault. Our generation, especially in the last 25 years or 30 years perhaps, started doing so much of aggressive intensive care that now everybody feels that's a responsibility. I see the question, how do you decide when it's end of life? I will come back to that, Savera. Not yet. Coming back to that screen that I was sharing, your objective in end of life is first and foremost that I should be as comfortable as possible physically and emotionally. I don't know if you have met my colleague Amrita yet. This is my colleague Amrita. And if I understand correctly, this elderly lady could laugh like that 2 weeks before her death. I also have the photographs on the same day when she is having this kind of faces. But between what she did and her, what is Amrita doing? She's not only being a doctor, she's being a friend. She's giving love and affection. And between them, that laugh, that enjoyment of life that is there, at least briefly on that woman's face, is about what we want to do. Physically, emotionally. I'll stop the screen sharing because Savera is asking a very good question. How do you know end of life care? You don't have an end of life care meter, do you? It is unpredictable, Savera. At least 10% of the time, it is unpredictable. One of my senior colleagues was giving a lecture at a conference in Kerala. Suddenly dropped dead. And the place was full of cardiothoracic surgeons and anesthetists, but they could not revive him. He had died of a brain hemorrhage. It can be unpredictable, but 90% of us go through a slower process. It can be unpredictable, but most of the time, there are telltale signs where prognostication of death can be possible. And maybe this is one thing that I would like you to Google for and understand. Does anybody want to contribute some ideas? What will tell you that somebody is close to death? What will change? Usual. I mean, you go home and ask your grandmother or grandfather, they will tell you. The extremity is getting cold. Your BP here may still be 90 by 60 or 110 by 70, but extremity is getting cold, peripheral circulation failing. Urine output dropping. It can be other reasons, granted. Slowly, reduction in the level of consciousness, especially the elderly without your medicines, at least 1/3, even up to 2/3, may get delirious. What did I say? Circulatory changes like reduced peripheral circulation, manifesting as peripheral cold feeling, diminishing urine output, diminishing level of consciousness, and abnormal patterns of breathing. And very close to death, memory clouding. Okay, Sandeep, correct. Memory, diminishing level of consciousness, diminishing, including delirium, or gradually slipping to stupor and coma. True. And at some point, breathing pattern changes. It may become periodic breathing. And towards the very end, usually there is jaw breathing, that kind of breathing. Now, this can be reversible. Sometimes somebody who is having jaw breathing the next day wakes up. It's also possible, particularly in hepatic disease, this kind of ups and downs are more likely, but most of the time, these signs show you that somebody is dying. So, I'm sorry, Raju, please remember to drop me a message. In the next time I am doing this, at least I must include a slide on prognostication of death. At the end of the session, I'll forget. That's why I am requesting you. So this is our objective, to make me comfortable physically and emotionally. Can you improve my symptom control? I need to be comfortable. Now you have a problem. My circulation seems to be dropping. Can you still give the morphine? We'll answer that question. Can you stop some of the things that I don't need anymore? Why should I continue the statins for my cholesterol at this stage? I'm hardly eating anything and you are still giving me my daily atorvastatin. And if my BP is only 100/70, why am I continuing those antihypertensives? You may have to continue my insulin. Some things may have to be continued, otherwise I'll be uncomfortable. But certainly at that stage, for heaven's sake, drop the routine blood checks. Don't bother about the serum sodium. Serum sodium will drop. That's part of the dying process. Serum sodium can also drop in some correctable disorders. That's another thing. But in somebody dying, no need to check the serum sodium if there are telltale signs of dying. But even if you find the sodium to be low, for heaven's sake, don't attempt correction in the dying person. I'll tell you why. Why do people get hyponatremia when they are dying? Yes, Sandeep, most medications are not needed. Some are. We'll come to that. But why do you think serum sodium drops? Is it always because of salt deficiency? You remember the sodium pump? Where does the sodium pump function? You in your body, sodium is predominantly extracellular. It's not necessarily of complicated things like SIADH and kidney dysfunction. Think of this. Now, as you are sitting here and as I am sitting here now, sodium is predominantly extracellular. When it goes into the cell, it is pushed out. The security staff pushes it out. It doesn't have entry into the cells except in a small quantity. That is a sodium pump. Sodium being pushed out of the cells all over my body, every single cell. And that requires energy. It is an ATP mediated function. But if my body is so weak, whether it's be because of a correctable disorder or non-correctable disorder. If my body doesn't have the energy, if the cells do not have ATP, sodium cannot be pushed out. Most of the time, it is not sodium deficiency. It is just that the sodium is intracellular. Serum sodium drops. Intracellular sodium is high. And what would happen to the cells if the intracellular sodium is high? What would be the osmotic reaction to it? Sodium wants company. It doesn't stay by itself. It draws in water. Intracellular water rises absolutely bijli. And Priyanka, very correct. The person is dying, and because his energy cells do not have energy, sodium is not pushed out. Sodium goes in. You are having more water accumulation. Cells swell. And now you are giving hypertonic saline. Happens in intensive care units all the time. In a correctable lesion, that's another thing. But in the dying person, all that hypertonic saline means more and more sodium happily enters the cell, cannot be pushed out. That draws in more water. Cells keep swelling. And a swollen cell further compresses the capillaries around it, further reduces the oxygen availability, further reducing ATP availability, which is why eventually after 3 weeks of intensive care, when your relative is brought out, you don't recognize him because he's a bloated body there. So, Chetana, Bijli, Priyanka, everybody else, you're absolutely right. Unless there is enough ATP in the cells, hypertonic saline will worsen the problem. Water accumulation will occur. And remember, the water accumulation occurs in the lungs also. In the membranes between the alveoli and the capillaries, alveolo-capillary interstitial space gets more and more filled. Already I am finding it difficult to breathe. Now I like to try even harder to breathe. We are harming the patient by treating that hyponatremia in a dying person. I will repeat. It may be because of a correctable disorder, in which case sodium replacement is necessary as you are correcting the basic cause, like an infection, like the reaction to chemotherapy, general weakness. All those are things that can recover, and there the treatment is different. But in this context, the situation is not salvageable, and therefore this serum sodium check, ABG, will help only to blot up your bill and to blot up the patient, not to improve the condition. Now, one of the problems is some of the medications will still be needed. Like my morphine. Now, please don't poke around trying to find a vein. Except for antibiotics, which may not be required at this stage at all, every other medication can be given either rectally or subcutaneously. By all means, give me a subcutaneous fluid if I am terribly dehydrated and uncomfortable. Or give me subcutaneous morphine. So much less painful. In that time when I am dying, my resistance will be low. I'll easily get phlebitis. So these are some of the simple things that we can do in the dying phase. So everybody, Priyanka gave the correct answer. So Priyanka goes back to her hospital. Sorry, Priyanka, I don't know where you are from. But when you go back there and give these revolutionary ideas, you will get slapped on the head. Crazy girl, they will say. So these are discussions to be generated among peers. And when you are strong enough, you try to get a proper end-of-life protocol. End-of-life care protocols are necessary for NABH accreditation. So these discussions will happen. What happens usually is that the proper end-of-life care protocol will be in the cupboard. It may not be translated to practice. It's up to us, all of us, to advocate for this and make this happen. When I am lying there at that point of time, Sajini, you feel pretty sure that I am dying. Stop asking what is my BP. You may have come to a stage which is no longer relevant. Ask how is he? Is he comfortable? And don't necessarily insist anymore on changing the position too early. If my skin seems to be intact, maybe you can allow me to rest for a while longer. And by all means, give me a air bed, so that I don't want a bed sore even on the last day. That may still be painful. But balance is based on comfort. The nurses have been taught to hourly change a position, but if the nurse has learned palliative care, she will say stop. Not yet. He's sleeping now. Let him sleep for a while longer. So as I said, if he seemed to be unconscious in the last few days, I have been on morphine for the last 3 months. Would you stop it? You should not. Don't stop it abruptly. For one thing, I may still get withdrawal symptoms which you will not be able to see. I may feel it inside, I may be uncomfortable. When you see me unconscious, you are only seeing that I cannot respond. Unless you do an EEG and you are an expert, you can't know whether I have any perception inside. I am feeling anything or not. You don't have a feeling meter. You will have to continue morphine, but the dose will have to be customized. Frequency will have to be customized. If the urine output is dropping from 4 hourly, gradually switch to 6 hourly, 8 hourly, or 12 hourly. And the dose you may reduce to 2/3, and if necessary at some point even to 1/3, because you know the urine output is dropping and body's requirement is dropping. Metabolism is dropping, so blood level is likely to rise. But continue at least 1/3 the dose till death. And even if I am apparently unconscious and breathing like this, come and talk to me. What do you lose? Maybe somewhere inside I can hear something. Give me a word of endearment. Rajagopal uncle, are you uncomfortable? I may not be able to answer. We are here to look after you. We will do everything for you. Your family has come, do you know? Your wife is here, your children are here. Talk to me. Why not? And before you just switch me around to the other position, please tell, uncle, I am changing your position. Uncle, I am turning you to the other side. Uncle, I am giving you a subcutaneous injection. Please give me that. Do me that favor. And please don't forget my family. You know that this is a very, very difficult time for the family. And if my wife is nagging you and all the time asking questions, oh, how is he? Do you think he is cold? Oh, he seems to be shivering. Please understand, she has a reason to be anxious. Just convey to her, Auntie, I see you are in a very difficult time. I promise to do the best for him. You want to do the best for him. We also want to do the best for him. And if they want to be with me, Allow them to be. And particularly don't forget children. Everybody forgets children. We all love children, but we forget them. Children need closure. I love my grandchildren. They love me. And all of a sudden, if I start disappearing without anybody telling them anything, and they are forced to see my dead body, or they are sent away to an uncle's house and not even allowed to see my dead body, and all of a sudden, you tell them, Grandpa has gone to heaven. Oh God. Oh, that kind of thing happens. Oh my God. If my dad also goes to heaven, mom also goes to heaven, who will look after me? Will I starve? Children have all these doubts inside them. And my grandfather, is he getting enough to eat in heaven? He doesn't know, that child. Remember, children need the truth given with compassion. As much as children want to know, they may not be ready to know. Children need information. And depending on religious rites, please facilitate rites, beliefs by the patient's belief system. And if the patient is unable to communicate, by the family's belief system. And that touch of the daughter on the forehead, that drop of water down the throat, oh my God, they are so precious for the dying person. And that's what we deny in the intensive care unit. So, but we work in an environment in India where it is norm, if the patient has enough money to come to a big hospital, especially a corporate hospital, to shift them to ICU. Usually the family doesn't have a say. Somebody puts an oximeter and you find it to be 87%. Oh God, 87, ICU. Before the family can get their bearings, I would be in the ICU. And the family is outside. Even if I have expressed my wishes, this may happen. And unequivocally, futile and inappropriate artificial life support measures usually cause physical, psychological, and social suffering to patients and families. Where the life can be restored to reasonable quality, this becomes necessary. Even there should be palliative care so that their suffering is relieved. But in a dying person, this is totally unjustifiable. What the healthcare system in India does to people who can afford to do it today is unjustifiable. Today, the healthcare system is kinder to the poor people, at least allowing them to be home, and cruel to the richer people. Please remember this about yourself, about your family members, your loved ones. People need palliative care at that time. And if you stop that ventilator in this man, we know he's dying. Well, human beings are not machines, so we feel reasonably certain that he's dying. And I won't go only by my judgments, I'll get a colleague's opinion. That's how we cross-check. If the person is going, if I stop the ventilator, I am making this statement that is not euthanasia. Allowing natural death is not euthanasia. Allowing natural death is not euthanasia, I repeat. Allowing natural death is not euthanasia. Euthanasia is the intentional act of killing a terminally ill patient. Euthanasia is on voluntary request, but for the purpose of the good of the patient, all that is granted. But euthanasia is killing. Somebody is dying and allowing them to die is not euthanasia. That might be a compassionate act in this context. And there is nothing called passive euthanasia, despite the fact that the 2018 Supreme Court judgment talked about passive euthanasia. This again is from the official ICMR document. The term passive euthanasia is obsolete terminology because it should be avoided, because euthanasia cannot be passive. Euthanasia is killing. It cannot be passive. You know what happens in the USA. They allow they call it assisted suicide. Connect the lethal infusion with the whatever, potassium chloride and every other thing. Connect the drip. Allow the patient to open it. The doctor doesn't open. Control is given to the patient. And they call it assisted suicide. But euthanasia cannot be passive. And as the ICMR says, withholding or withdrawing a potentially inappropriate treatment cannot be construed as an intention to kill, and that's not euthanasia. So if you are withdrawing a ventilator, it is not euthanasia. Please, doctors, Chetana, Priyanka, Bijli, anybody who was chatting with me, anybody else, please do not think that you will be performing euthanasia if you will stop my ventilator. You are giving me decent, compassionate, scientific medical treatment. But before doing that, before withdrawing my ventilator, you will have to ask a few questions. Have I left an advance directive, which is otherwise called a living will? Let me tell you that in my case, I have. I don't know about you, how many of you, but I would encourage that everybody should do it. I have written saying that in such and such and such instance, I should be allowed to be with my family and not in an intensive care unit. Such and such artificial life support measures should not be done on me. Now, how do you decide whether I am salvageable or not? 3 physicians perform an evaluation, and all 3 agree that yes, this is correct. And of course, this is vitally important. You are convinced that my life is not salvageable. I have left my advance directive, but still, please sit down with my family. They will have many questions. Don't consider them adversaries, even if they are saying, no, keep him alive. Acknowledge. What I'll tell them is, Lucy, I see that you love your father very much. You want to do the best for him. Mr. So and so, I assure you that I also want to do the best for him. Let us talk about together what we can do for him. You are not adversaries now. You are on the same side. And now some discussions are possible. My son may ask for time. And if you have given only realistic treatment options and allow time, continue the existing measures. Do not escalate treatment. Do not add one more life support and one more life support. And if my son says, okay, but don't take away the oxygen, continue the oxygen. Maybe you can allow it. It doesn't harm me very much. Don't bring in the cost now. If you say it's also going to be needlessly expensive, my son will say, my father is dying and I don't want to talk. Money is not the matter. So no guilt. Do not reinforce guilt. And most importantly, ladies and gentlemen, look at the last bullet point. Never ever say there is nothing more to be done. There is always something more to be done. Even when I am dead, till I am dead, you have to keep me comfortable. So never tell the family there's nothing more to be done. By all means say the ventilator is not going to help him, but we will continue to do everything to keep him as comfortable as possible for as long as possible. That's the truth, isn't it? That's what we should say. You should also know that according to the Supreme Court judgment of 2018, advance directives that I have left are considered valid and binding on doctors by the Supreme Court. But the court suspected that some relatives may want to play foul games. Therefore, they put in some catches. They say advance directive has to be countersigned by a magistrate. That even then, before withdrawing a life support, not only a 3-member medical board in the hospital, but a second 3-member board appointed by the district collector also should examine me. And also the magistrate should come and personally verify that I am real. And these things cannot be done. In 2.5 years, I am not aware of even a single person who has had withdrawal life support going through this procedure. Just not possible. But I was one of the members of an ICMR committee taking decisions on the course of action. And the lawyers there clearly advised that primarily your duty of care is paramount. All these procedures that the court advises become necessary only if there is a challenge. If my family has agreed with you, then there is no problem. Patient has left the wishes or may not have left the wishes. 3 doctors feel the same way, and the family feels the same way. Let my father go, is what my son say. And at that point, you withdraw the ventilator. All these procedures are not necessary. But if there is a conflict of opinion, then we'll have to work out to resolve the conflict. And then only a solution will occur. Till Government of India passes a law on this matter, we do not have a law on this matter. So before I conclude, let me bring up these most important points to remember. You must keep me physically comfortable. Find out what is the most important for me. My connection with my family, or sometimes even with my home, will be the most important. Try to restore the connection. I am not emotionally connected to the ventilator. I am emotionally connected to my family. Please restore that connection. Don't leave me alone. I may be scared. I want companionship. If I have no family, I hope you won't mind coming in once in a way. Sit down for 2 minutes. I know, doctor, you are busy. I'm not asking you to stay with me all the time. But those 2 minutes you are giving me, don't stand and talk down at me. Sit with me. Hold my hand. Convey that you care for me. And that's all I ask you. If I have 1 year or 1 month or 1 hour, I would like it to be as meaningful as possible. And at that time, that meaning may be brought in by knowing that you care for me. That meaning may also come from a kiss that I'll get from my grandchild. And remember this quote from Paracelsus, 15th century. The most fundamental principle of medicine is love. It may not be in Cecil and Loeb or Davidson's textbook of internal medicine, but Paracelsus wrote this more than 5 centuries back. And I believe strongly that is still valid. And when my time comes, dear doctors, this is what I would request from you. Thank you.
Thank you, sir. So I think when we go through this lecture, you may have doubts. There will be some points which need to be clarified. So it's open to discussion. Any of you can have your comment or questions, please.
Chetana has said children might not be able to communicate their doubts. True. It also depends on age group. At any age, the communication has to be age appropriate. Till the age of 5 or 6, children cannot understand that death is permanent. So you say, mommy is dead. And he may say, okay, so when will she come back? And you say, she will never come back. But if I am a good girl, she will come back, right? This will be there. And as they grow older, they go through different things. Especially adolescents may not be able to talk freely. Children between 6 and 10 may be the most forthcoming, expressing their fears, etc. If they are not in a challenging environment. If we are able to be friends with them, they will ask the doubts. They may not ask you doubts, doctor, because they are afraid of you because you are known to give injections, but they will ask the uncle. Questions and discussion, please. Thank you, everybody, for expressing the thanks. I enjoyed it. Oh, what if this patient is not willing to take morphine? Priyanka, listen. We talked about ethics, right? Raju, did I do ethics for this team?
Yes, sir.
Okay. What was the most important principle that I mentioned? Overriding medical ethics, autonomy. It's up to me. Priyanka, I don't want your morphine. Whatever you do, I don't want your morphine. What Priyanka should be say, if I am conscious and competent to take decisions, sit down with me. Say, certainly, uncle, I won't give you a morphine if you don't want it. That will reassure me. And then sit down, Priyanka. This conversation should be sitting down, not standing up. Sit down with me. Say, if you say you don't want morphine, there must be a very good reason. Tell me what it is. And then I may open up. But you cannot, so long as I am competent to take a decision, you cannot force anything on me without my permission. But if I am saying that because I am delirious, you will have to treat my delirium. And then the decision making, ethically and legally, has passed to my next of kin. Vandana Khan says we should be working on some case studies of dignified death.
Yes, sir. Yes, sir. I think we need to talk more about what is dignified death. Is it the death? Because this is a question I was asked some time back by some of my colleagues who actually are not doctors, but they thought like when we work on palliative care, they all should die in hospital. But then I've been thinking on these matters, and a dignified death, for what does a dignified death is for a person itself who's dying, and what is the concept of the relatives or the family members who are around them.
Raju, sorry, I want to share the screen. Don't stop it. Sorry, Vandana. I interrupted you.
Sorry, sir. Sir, one case, very quickly, I'll tell about a lady who who had a dignified death, when she actually was able to reconcile with some of the people with whom she was not talking, her own very like close family members. She had a dignified death when when she was at mental peace and emotional peace, and she was able she was not discriminated because of her cancer. Then she had this dignified death, and other family members, they were able to come together and work for her and contribute to her money towards her, like whatever the living and all. So when we talk about these and we have this like I'm not talking about I'm talking about my context, like because we don't talk much about dignified death. What happens is everyone wants to live. Even sometimes the patients, I've seen patients who want to live. Even if we say yours is a like because some of the doctors in my hospital, they get fed up, say ye to palliative care patient, he's about to die, why he wants to live? And that is the decision becomes very difficult to make. Like who makes the decision now? So so we should have those concepts of some this understanding. So I know every case study is different, but there will be definitely some process which actually talks about steps, what exactly a dignified death looks like. It's not only at the end, but also a process when a person is first diagnosed with a terminal illness. This is just my thoughts, sir. Sorry for taking your time.
To start with, you asked what is a dignified death, and I thought I would show this picture again. This very poor woman who was in a destitute home because her son-in-law was a drunkard and would beat up her daughter, and she couldn't have a home there. But in her last days, that hand on the forehead, her morphine, which kept her comfortable, and those few drops of water, they gave her dignity. And these arms bound, legs bound, tubes everywhere, but you know that's the extreme opposite. Back to, was it, sorry, it was Vandana who said that, right?
Yes, sir.
Yes, yes. Vandana, it's again a question of autonomy. Vandana, I actually had a patient when I was doing palliative care, anesthesia, and intensive care all together. I actually had a woman, elderly woman, who said, "Doctor, I don't care what you do. Keep me alive till the 25th. Even if I am on life support, my son is coming on the 25th. I want him to see me alive." We respected her wish. Even though she was having advanced cancer, we put her on a ventilator. We were very sad that she died before he arrived, but that was another thing beyond our control. But we respected her wish. And I believe, Vandana, in that context, putting her on that ventilator was important for her dignity. Milan is relating a personal story. When my dad was on last stage, was on ventilator, doctor said he would not recover. So we children should take the decision to discontinue life support. But when they came to know that he had insurance cover, they went on saying that we'll wait for 48 hours more. Oh my God, prolonged for 4 more days. Milan, can I see you?
Sir, I don't have a video here on this laptop.
Milan, my heart
Yes,
goes
sir.
out to you. You must be a very angry person.
Right.
This is part of the reality in this country.
Yes.
Possibly globally, where, look, my God, money rules healthcare.
Exactly.
And this was illegal, not only unethical, but we cannot prove it. So you, Milan,
Yes, sir.
there is only one thing that I can suggest that will get some good come out of your anger. Tell your story. Write down your story. You may
Yes.
not publish it in a newspaper immediately. It will benefit you because it will be cathartic. You don't have to be a writer.
Okay.
Just as the way you tell me the experience, write
Yes,
it
sir.
down. And
Okay.
then these stories need to come out.
Right.
That is one thing you can contribute. I totally believe. Oh, I have overshot time by 5 minutes. I believe each one of us can change the world. When you have brought a smile to a face that had tears, you have already changed the world a little bit. I believe every little bit of effort matters. Milan, I am putting in my email ID here. Please let us continue the conversation. Happy to receive emails from any one of you, of course. This is my email ID, chairman@palemindia.org. Do please write to me, Milan. I must stop because I have overshot time by 6 minutes already. Sunil must be very, very annoyed with me. Thank you, everybody. Thank you for that warm interaction also.
Thank you, sir, and making us all to know the importance of love and compassion during end of life care. So let's move on to the patient story, which will be presented by Dr. Sabita. So, Dr. Sabita, so over to you.
Good afternoon, everyone. Thank you. I am Sabita. I'm a pediatrician, and I got permission to be an observer at Dean Foundation Hospice and Palliative Care, where I accompanied the palliative care team to visit the patient that I'm presenting at her home on 2 occasions. Next slide, please. The patient is 53 years old, and she's been diagnosed with carcinoma of the left buccal mucosa, squamous cell carcinoma with the staging of T4A N1M0. She presented at the government hospital here in 2 years ago with complaints of pain in her left cheek, which had been there for almost a year, but which she didn't think was very relevant, and then a swelling of the left cheek for the past 4 days. She then was referred to the Dean Foundation the next year, almost a year later, for management of pain and ulceration. Her pain rating was 6 out of 10. It was intermittent, aching, and sometimes pricking, and it was relieved with analgesics given. There was an ulcer of her left cheek, fistula, draining saliva, and blood-stained pus. Mrs. K had habit of chewing betel nut for many years, and she initially presented in 2018 with pain and swelling of the left cheek to the Government Medical College Hospital here. Investigations showed grade 1 squamous cell carcinoma and histopathology. She was treated with radiation and chemotherapy, cisplatin, but she developed renal dysfunction. Creatinine was at 1.4, and hence the chemotherapy was stopped. The diagnosis was reassessed and made as recurrence of squamous cell carcinoma with maxillary and mandibular involvement and retromolar extension. She was started on palliative methotrexate, and she was told to go to Dean Foundation for management of her symptoms. The oncology team had planned salvage surgery, but that was put on hold because of the COVID-19 situation. At her initial presentation to the government hospital, she was also diagnosed to be hypertensive and started on an antihypertensive. At the palliative care center, she was initially seen at the outpatient clinic, and then later on, when she became too weak to come there, and also during the COVID times now, she has been looked after through home visits and through telephone follow-up. The ulceration in her left cheek has grown over the past 6 months, and she has lost a lot of weight as eating has become much more difficult with food spilling out of the wound. Every time she has her palliative methotrexate, which is given fortnightly, she becomes even weaker and develops mucositis. And she was managing, but then just recently on 15th of September, she complained of difficulty in swallowing semi-solid food. And so the team decided to insert a nasogastric tube, but she wasn't comfortable with it. And within a few days, her husband phoned up to say that it was irritating too much and they're pulling it out. She's now on a liquid diet of juice, rice water, and a protein powder that Dean Foundation provides. All her medicines are powdered and mixed with water and given. Her initial ECOG and performance status was 2 in the initial stages of her being assessed at Dean. She was ambulatory and she was able to take care of herself, but she was not doing any other work. And she was up and about more than 50% of waking hours. But then ECOG, the performance status decreased to 3 after every dose of chemo. And it's been at 3 for the past 3 months. So she finds it very difficult to take care of herself. Her husband takes care of her completely. He has not been going to his job for many months now. She's confined to a bed or chair more than 50% of waking hours. She spends that time sitting on her bed. It's just a one-room house, watching TV. She likes Rajinikanth movies. And sometimes he takes that plastic chair and puts it outside that house that she can watch her grandchildren who live nearby play around. And she needs help in assistance in walking. Her pain is well controlled on morphine and also other drugs. There is only breakthrough pain during dressing of the wound, and sometimes she complains of pain after her chemotherapy. Next slide, please. On examination at the Palliative Care Center last year in September, she was actually a moderately built lady, but it's recorded that she appeared withdrawn. Her BP was 200 or 120 millimeters mercury. There was no pallor, icterus, or clubbing. The left cervical lymph nodes were palpable. There was an ulceration of the left buccal mucosa with a white patch present and an orocutaneous fistula draining blood-stained fluid and pus. All other system examination did not show any abnormality. Next slide, please. Treatment at the government hospital, investigations done included a biopsy, which was reported as grade 1 squamous cell carcinoma. A CT chest showed evidence of obstructive airway disease. Echocardiogram was normal, and all the other blood tests were normal. The creatinine rose up during the chemotherapy to 1.4, and that's why the chemotherapy was stopped. But it came back down to 1.1 this year in August. Her hemoglobin last year was 11.7. This year it is 8.6 milligrams. Her albumin recorded last year was 3.9 grams per deciliter. She received radiotherapy, chemotherapy, and is now receiving palliative methotrexate at the government hospital. Next slide, please. At the Palliative Care Center, she was started on tab morphine sulfate 5 milligrams every 4 hours with 10 milligrams at night. And after a week, this was increased to 10 milligrams Q4 hourly. She was also started on tab Bovaran once a day, Dulcolax 5 milligrams, 10 milligrams at night, Perinorm BD, Pan 40 BD, amlodipine for her hypertension. It was at 2.5 milligrams, 5 milligrams OD, and increased to 5 milligrams BD. Tab Angsit 0.5 milligrams at night because every time they saw her, she seemed anxious and worried about the ulcer. She was also given Candid mouth paint or a fresh mouthwash. Other medications that were given over the past 1 year that she's been taken care of at Dean Foundation includes tab dexamethasone 0.5 milligram BD for 10 days. This was given, I was told, when the ulceration there was a lot of swelling and pain around the ulcer. Tab Ketonor 1 tablet BD, tab Chimeral Forte BD, She had also complained of numbness and tingling in her cheek, and pregabalin 75 milligrams OD was prescribed along with iron and folic acid. Every day, the dressing of the ulcer after 2% xylocaine spray is sprayed, and it's cleaned with normal saline and betadine. It is dressed with a paste of metrogel and turmeric and betadine. And the husband was taught how to do this, and all the supplies were also given to him. The home care team visits the home and every 10 days and does one dressing, but the remaining time, her husband takes care of it very well. Next slide, please. The patient is a 53-year-old housewife. She's married. Her husband is an auto driver. They have 3 daughters and 2 sons, and all are married except for the youngest son. Both sons are also auto drivers. 1 daughter and 1 son live on either side of Mrs. K's house, along with their families. In the initial visit to the palliative care center, it was noted that the patient appears withdrawn, depressed, and feels guilty. When she was asked directly what were her chief concerns, she mentioned financial concern and children. Financial because especially during the radiation and chemotherapy, she needed a lot of help, and her husband had to stop working, going for getting customers through the auto. And she was worried about finances. And also, of course, during COVID time, in general, there were not many customers also. And she was concerned where they would get the money. She was also concerned about how much support she'd get from not her daughter, but her daughter-in-law in helping her out if her husband went to work. And about her children, her main concern was that the eldest son and wife, they did not have any children, and the youngest one had not yet got married. Other concerns were her appearance. Every time she comes to the outpatient clinic, she brings a photo of herself and her husband, taken many years ago, where you can see that she's a very well-built lady, and she takes it on and says, "That's who I really am. This is not me." And in fact, when I went and visited her the first time in September, she insisted that her husband take out that photo and show me and say that that's how I looked like. And that seems to have been an ongoing concern for her, that I think about her body image and how she appears. She said that I don't feel that I am a good match for my husband, that we don't look as if we are very compatible now, but we were a very good couple then in the photo. She also struggled a lot with not being able to eat. She used to enjoy her food, and her husband says that she could easily eat a plate full of chicken fry, and she used to really enjoy her food. And now that it's come down to just having rice water and things, she finds that difficult also. And one of the most common question asked at every visit is, how long will it take for the ulcer to heal? Next slide, please. The patient was told the diagnosis that it was cancer at the government hospital, but prognosis was not discussed at any point at the government hospital. At Dean Foundation, the prognosis was discussed with her husband by the team, by the doctor there, but the husband does not want his wife to know yet. She's a very spiritual lady and very religious and attends prayer meetings regularly. When I saw her just this month for the second visit, there seemed to have been a change in the sense that she never brought up her appearance, and she made this one statement: "I'm happy to submit to God's will for me, but I would like to see my younger son get married and the older one have a child." Next slide, please. The financial main concern for Mrs. K is the financial concerns actually being taken care of. Both her sons are very supportive. When she needs to go to the palliative care center or to the government hospital, they make themselves available for that. And they always give 1,000 rupees to them. The daughter who lives next door, asks the dad to go to work, and she comes in after her housework and brings the juice and the rice water for her mother. So when I last talked with them, both of them were in fact very happy that they had 5 children. They said people used to laugh at us saying with 5 children, how can you manage? But we have saved money and educated them, and look now how supportive they all are. So right now their concerns about finance are not so much. But her major concern now, it looks like, is that without even knowing the prognosis, she somehow has accepted that her life period may be limited, and what she wants most is to be able to see her younger son married and her elder son have a child. Next slide, please. In summary, this is a 53-year-old lady with stage 4 squamous cell carcinoma of the left buccal mucosa with recurrence after initial treatment, currently on palliative methotrexate, receiving palliative care, and showing a steady deterioration in physical health and function. Next slide, please. Discussion points, nutrition and hydration. Her nutritional status is very bad. She's lost a lot of weight, definitely more than 10%. She doesn't want the nasogastric tube, so she's attempting to take everything orally, fluids, but even with that, unless she positions her head in a particular way, some of it does go onto that side and drools out and things like that. So is this a good time to start thinking of subcutaneous infusions right now? And then end of life care decisions. There is a certain amount of collusion, so should a meeting to prepare them psychologically and practically be planned? What happens when she reaches that time? And counseling and management of distressing end-of-life symptoms. What would she and the family like to be done then? And also, just for future, system of communication between the government oncologists and the palliative care team, because there was absolutely no communication. So, for example, to be on the same page regarding the palliative methotrexate, or what all information has been shared with the patient, etc. Thank you very much.
Thank you, Dr. Sabita. So, anybody want to give your opinion regarding the nutrition and hydration in this patient? Anybody? So this patient has a orocutaneous fistula. In addition to her probably loss of appetite. How was her appetite, Dr. Sabita?
Sorry, sir. Actually, now it's no longer a fistula. It's completely, the skin has been completely, eroded over the entire left cheek. So exposing both maxillary bone and mandible bone.
Okay. How was her appetite?
I would say it's average. It fluctuates. The times just after the methotrexate injections, everything goes down. She doesn't want anything. But after that, it is average, I'd say. She does want to eat.
Okay. So somebody was going to speak.
Sorry, sir?
No, I think somebody was going to answer some of the questions. I don't know who was it. Anybody? What should be done for nutrition and hydration? No comment? Okay. Yeah, there are few comments. Subcutaneous infusion can be started if they agree. Okay, subcutaneous infusion is a good option. Okay, so here we have a patient who has a stage 4 carcinoma, and whenever she receives chemotherapy, her performance status is decreasing, and in addition, her general condition is gradually deteriorating. So first of all, we need to think whether nutrition and hydration is going to improve the patient's general condition. It is not going to improve the patient's general condition, but just for maintaining the hydration or patient, if she has appetite, she can continue to take. Am I not audible, Rajalakshmi?
Yes, sir, you are.
Okay. So a patient with advanced malignancy having a stage 4 disease, the role of nutrition and hydration is not actually we have to allow the patient whatever she wants to eat, and she has specifically told that she doesn't want a rice soup. So I think we have to respect her wish, considering this is a stage 4 disease. So whatever she is taking orally, that can be encouraged, and maybe a straw, if it is helpful, I don't know, we have to try, because whatever she is taking in may be coming out through that wound. So sometimes a straw can help, which will place the fluid into the throat. So that can be tried. And if she wants some fluids from a medical point of view, I think whatever she is taking in should be enough. But if you feel that she is not getting anything inside because of the wound, maybe subcutaneous hydration can be done. This is just for getting some fluid to go into patient. Maybe 500 ml of normal saline can be given every day, and this can be taught to the caregiver. So they can do it. It doesn't require much professional help.
Yes.
The nutrition and hydration at this stage of disease is not something we need not aggressively manage the situation with a lot of nutrients and hydration. But something has to go in. You can try subcutaneous fluid. But first of all, you have to, this patient has refused the right tube insertion. So you have to ask her, do you want something like subcutaneous infusion, which would be less painful compared to
NG. So. Hello?
I think Dr. Sunil have left me. Dr. Sunil, can you hear us, sir?
I lost my connection for a moment. Am I audible now?
Yes, sir, you are.
Okay. So I hope the question number 1 has answered. Dr. Sabita, do you have anything to add or anything to ask regarding that question number 1?
Yes, sir. Just two things. One is,
Yeah.
From what I've learned, that the patient is not yet at the end of her life, but she's approaching it quite soon, within a few months.
Yeah. Yeah.
At some point, even the morphine may have to be given subcutaneously and.
Okay. So I don't know how many of the palliative care team have injectable morphine. So the usually available would be the tablet. So the problem would be if the patient is unable to take anything orally, then injections may not be available. So what you can do is you can use morphine parenterally. The fast-acting tablet can be used parenterally. You can make it a paste and maybe with the 2 drops of water. It can make you can make a paste and rub it over the rectal mucosa. That will give the same effect as oral route.
Oh, I see. Okay. Thank you.
And end of life care decisions to prepare. Here the patient knows that it is a cancer, but she doesn't know about the prognosis. So I think it is important for us to talk to the family, because the husband don't want to reveal the prognosis to the patient. Yes, so it is important to have a family conference, probably with father and the children, and discuss these things with the family, and tell them that it is important to talk to her regarding the prognosis also, because she want to see the marriage of her son. And you also told one more concern. I don't remember what it is.
Eldest son should have she wants to see a grandchild, eldest son.
Yeah. So that we don't know, but maybe we can encourage the family to make the marriage happen at the earliest date,
right, yes.
So that her wishes can be respected. So it is important to have a meeting, family conference. So in this situation where there is a conflict, it would be important to have a meeting with the patient and with the family, and then we are always on the side of the patient. Yes. So it's our primary duty to serve the patient. So it is important. So once this meeting has happened, we can talk to the patient and ask her wish. If you are going to deteriorate further, where would you like to get the care? Is it in the hospital or is it in the home? And what type of treatment would you? What type of treatment do you prefer? Maybe if you are coming to a hospital, what type of treatment do you want to be put on a ventilator, etc., etc. We can also talk regarding what should be beneficial for the patient at that time. Yes. So ICU, ventilator, these are not good, etc. Those all can be talked regarding to the patient, and then come to a decision. And what are the distressing symptoms that usually occurs at the end of life? That can be anything. Okay. So anybody want to comment on this? What would be the distressing symptoms at the end of life, and how can we manage this? Anybody? Bleeding. Yeah, in this patient, that's a possibility that we have to consider. Hypertension, oliguria, delirium. Yes, yes. So bleeding is something which we have to definitely consider in this patient. And if that happens, we have to actually prepare the family for that. So stage 4 disease with severe bleeding, we are not going to advise the family member regarding any active treatment during that bleeding episode. We can actually tell them that we will make her comfortable, and you can use some colored clothes to collect the blood, maybe even basins if the bleeding is too much, and give the reduce the patient's anxiety by giving midazolam. And probably if the bleeding is severe, the patient will bleed to death. Delirium is one common symptom which occurs in patients during death. About 2/3 of the patients during the last period can have delirium. So it has to be managed properly. That needs haloperidol. If the patient is unable to take anything orally, then we have to give it by subcutaneously if the delirium is distressing. And sometimes breathlessness, pain, all these can occur. Breathlessness and pain can be managed with morphine, and breathlessness due to aspiration of secretion. That's also another possible thing. But we can keep the patient either in lateral position so that the secretions will come out. That will drain as per the gravity. So death rattle is something which can also occur during the terminal period. This can also be managed with left lateral or right lateral position. If this is not appropriate, or if that doesn't give much symptom control, then you can give either injection glycopyrrolate or injection buscopan, which will dry up the secretions. So these are some common symptoms which can occur during end of life. So, Dr. Sabita, do you have anything else in your mind regarding this?
Would we have to give the family some of these medications to keep with them in case this starts in the middle of the night or things like that? I mean, do we?
Yeah, and anticipatory prescription is very important. We usually give medications anticipating some of the distressing symptoms. That's very important.
Thank you, sir.
So a system of communication between government oncologist and palliative care team for the future. So if this happens, this would be very good. But many a times this doesn't happen, and the communication between oncologist is with the palliative care physician is very difficult. But when we get some patients and when we are in doubt, we actually call that oncologist over the phone and discuss with him. Such and such patients are admitted here, and he is in such condition. What is your advice? That will give you some clarity regarding what he has advised the patient and family. So that establishing that rapport with the local oncologist is very important, because most of the patients are going to come from him. So I think we can actually go and meet the oncologist, and if possible, we arrange a class with all the oncologists in that department, so that there will be a good rapport with them. That's what we usually do.
Yes.
Anybody else have any comments? Dr. Sabita?
Sir, no, that was very helpful, sir. Thank you.
Okay. I think we can wind up the session today. So thank you, Dr. Sabita, for this wonderful patient story and very good points to discuss also. Thank you. I think we should also thank Rajagopal sir for that excellent session.